Hi everyone, it's Georgia, CEO at Wype here. As you know, Wype is all about keeping bums clean, green, happy, and healthy. But something that you learn when running a beauty business for a couple of years is that there's a lot of shame, stigma, and embarrassment around what happens in the bathroom and our bowel movements and sometimes our gut health. And this stops us from being more educated, having healthy conversations, and sometimes, worst of all, going to the doctor. So we thought that this April, which is Bowel Cancer Awareness Month, it was a perfect opportunity to share some really helpful educational content and raise a little bit of awareness for people to be in the know, not to be worried, but to be informed. And we have someone to help us with that here today. It's Dr. James Kinross, our Chief Medical Officer. He's not only our amazing Chief Medical Officer at Wype, but he's also a colorectal surgeon and a senior lecturer at Imperial College and a really, really smart doctor. So we're really excited to have him here to answer our burning questions. Thank you, James. Really happy to have you here today.
Well, hey, Georgia, thank you so much for asking me to come and speak to you today. It's a real pleasure to be with you. I spend a lot of time talking to people about their bottoms. And in fact, the good British people love nothing more than to talk about their bottoms. And I suppose we're here today to talk about Bowel Cancer Awareness Month. And I would like to say that first and foremost, right out the gate, if you're worried at all about anything, please just don't be embarrassed. Come and speak to me, speak to one of your doctors, and there really is nothing to be embarrassed about because bowel cancer is a completely preventable disease. And what we know is that the sooner you detect it, the better your chance of having a complete cure and surviving, but also having a much better quality of life from those treatments. So if you're going to take one thing away from this conversation, don't be embarrassed. Go and get anything checked out that you're worried about.
All right, so I did a little bit of research to prepare for this call, and I was looking into bowel cancer statistics, and of course, some of them are really concerning, like, for example, that bowel cancer is the first cause of cancer death globally in non-smokers, which is horrible to learn about, and I think that's one of the reasons why we really wanted to kind of raise awareness about the signs and symptoms and everything else. But furthermore, something that I found out when I was reading is that bowel cancer rates are rising in younger people. Do you have something you can tell us about that?
The interesting challenge that you've identified is that the epidemiology of cancer is changing. So that means who gets cancer and where they live in the world is changing. And what we're seeing is a startling rise in bowel cancer in young people. So by young, what we mean is under the age of 50. That might seem quite old, I suppose, to some of the people listening to this conversation. But to me, it's really young. Because most of the people that we would typically see with bowel cancer would turn up in their 70s and 80s historically. But if you're what we now call a millennial, and I don't really like those names, but they're not particularly helpful. But if you were born in the 1980s, for example, or 1990s, your risk of bowel cancer is 4 times that of someone who was born in the 1960s or 1970s, and that rate is climbing. It's climbing rapidly, and we don't really know why it happens, and we perhaps can talk about my theories as to why it happens in a second. But the one thing that I would say is that it's young people that we as surgeons and as doctors are most worried about connecting with, because it's the young people that are typically the most reluctant to come and seek help, and when they do seek help, quite often their requests for help are dismissed because they're put down to hemorrhoids or something else that is thought to be more common in that age group, and then they don't get properly assessed. And by the time they come to see me, they don't have that early cancer that we were talking about. They typically have a later cancer with a worse prognosis. So if you're listening to this and you're in your 30s and your 40s, or maybe even in your 50s, and you're having symptoms that you're worried about, go and ask your GP for help.
Well, that's a perfect segue because it sounds like a lot of it comes down to understanding signs and symptoms. So just to go a little bit more into that, what are the signs and symptoms? What should people look out for? And what should the people listening to us today know about everything that goes on with our bowels?
The first thing to say is that actually the symptoms of very early cancer can almost be there are no symptoms, which is why we have a national screening program. And it's why we screen for the detection of blood in stool, because that blood can be microscopic and really hard to detect, or you might not have any change in your bowel habit. So if you are, called to have a screening test, it's really important that you do that screening test, because it allows us to detect these cancers early in a subset of patients. But if patients do have symptoms, they typically fall under one of the following categories. So usually patients will describe a change in their bowel habit. So what that means is that usually for a timeline of more than 6 weeks, they're having perhaps looser bowel motions than normal, or they're more constipated than they normally would be, which means they're going less frequently. It's not uncommon to have bleeding. And usually that bleeding is not bright red blood on the paper. It's usually dark or altered blood that you're passing as part of your bowel motion. Sometimes patients will complain of a sense of incomplete emptying. So they'll sit on the toilet and they'll open their bowels, and then they feel like maybe they need to go back 2 or 3 times because they're not quite able to empty their bowel. And sometimes there might also be non-specific symptoms that are slightly concerning. So weight loss or loss of appetite, and occasionally abdominal pain or abdominal distension. We know that about a quarter of all bowel cancers present, which means that they are diagnosed when those patients arrive in the emergency room, because the symptoms have got so severe, their pain has become so intense that they've had to go to see an emergency doctor. And we know that the prognosis for those patients is significantly worse. So what we want to do is to see you when you've got very minor symptoms, because at that stage we can give you a proper clean bill of health, and that's the likely outcome. And if we are going to find something, it's going to be early, and that means we can do more about it.
So it seems like a lot of it comes to paying attention to your gut health and your bowel movements, and understanding how your body is doing through those.
I think that's a really good point. So I think there's a lot of talk around themes like gut health at the moment. So gut health is very much in the public consciousness at the moment. And certainly I'm a strong advocate of optimizing your gut health. But what I would say is that if you're noticing a change in your normal gut function, don't ignore it. And actually, that's true for just about everything in healthcare, right? But if you're having a sustained change, ask for help. And it doesn't matter what those symptoms are. It doesn't matter how minor they are. You're noticing that change, and you should be able to take control of those symptoms and to seek help.
All right. So, as a doctor and a researcher with a huge wealth of experience, who sees patients on a daily basis, and researches, bowel conditions as much as you do, how do you feel about Dr. Google? It is an empowering tool for education, or is it a toxic way of spiraling into panic and anxiety?
I think we have to be pragmatic about this. And the takeaway message I would give is this: is if you're worried enough to be searching for symptoms on any online forum, then you should be seeking professional help, right? So that's the basic top line summary. Now, to be a bit more specific in my answer to your question, I would say that there are some really quite good resources out there online that I would really recommend. So obviously the NHS is trusted, but I would also recommend Bowel Cancer Research UK, Cancer Research UK. They've got very, very good patient information sheets that give really clear advice, and they're a really good source of information. I think the problem becomes when perhaps you are reading material which is not properly peer reviewed, and sometimes that can be misleading, or it can create anxiety and worry, which you don't necessarily need to endure, right? So I think I come back to my main message. If you're worried enough to be Googling for symptoms, you should be seeking help from your GP, and they can give you some more reassurance about what that really means.
All right. So far we've covered why you shouldn't be ashamed to go to the doctor, what you should look out for, and what your body is telling you about everything that's going on, how Dr. Google can be a friend or foe. Fine. Let's say that finally you decide to go to the doctor. What can you expect after that?
So if you're seeing a doctor, and you probably will see a doctor, the first thing they're going to do is they're going to listen to your story, and they should take what we call a history, which they'll ask about how your symptoms started, when they started, and how severe those symptoms are, and do they affect your quality of life. They might also ask about your family history. So is there anyone else in your family that's had bowel cancer? Because we know that's an important risk factor. And in keeping with that, they'll talk or ask you about other risk factors in your life that might increase your chance of having bowel cancer. So other diseases or medical conditions that you might have, for example. Of course, they're going to need to examine you. And that's the thing that most patients that I meet are really worried about or embarrassed about. Again, just don't be. Usually an examination means in the clinic, feeling just inside the bottom to see whether or not there's a mass there or anything that they could feel that shouldn't be there. And that's important to do, because if you find it, you can immediately do something about it, and it increases your the speed that you're going to go through your next kind of bit of your patient journey. They will then often make a decision as to what to do next. Now, some primary care doctors will do something called a FIT test. A FIT test stands for a fecal immunochemistry test. And what that test does is it detects the presence of microscopic amounts of blood in your stool or in your feces. And if that test is negative, there's an overwhelming chance that you do not have bowel cancer and that you can relax. So if you've got a negative test, there's about a 98% chance that you're going to be okay. Now, if you've got a positive test, all that test really means is that you've got blood in the stool. And what the reason we do that test is that cancers or polyps which are kind of precursor or early lesions of cancer that line the bowel, they are delicate and they often pass a tiny little bit of blood in the stool. We're aiming to detect it. Now, there's lots of reasons why you might have blood in the stool, from sort of hemorrhoids through to benign conditions of the bowel. And so at that point, if it's positive, your doctor might say to you, look, okay, we think we need to have a look inside your bowel. And generally, there are two ways of doing that. There's either a way where we can look with a bendy telescope, so a flexible telescope or camera that looks inside the bowel, and that's called a colonoscopy. But we can also do scans. So there's something called a CT virtual colonoscopy, and that's where we do a special X-ray of your tongue. And I could explain a bit more detail if you're interested in how we do it. But it means that it's a less invasive way of doing it, because you don't need to have a camera that's passed inside of the bowel. But those would be the current gold standards for how we would then definitively rule out the presence of a bowel cancer.
I want to focus on something that you mentioned earlier, and that I was thinking about myself, is that it seems like a lot of people have issues in going to see the doctor concerning bowel symptoms and things that seem to be going wrong on the toilet. Ultimately, A, because they don't want to talk about it, and B, because they're afraid of having to show their bum to the doctor, or worse, even having had something put in or around their bums. So how do you feel about that?
Yeah. So look, the privilege of my job is that I get to work with people, and you see like the whole spectrum of responses to this. I think most people are obviously a little bit, anxious about it. I mean, why would you not be? And I think most people worry that either it's going to be painful or that it's going to be embarrassing. So the first thing I'd say is that typically, when this examination happens, there should be a chaperone in the room with you. So as a male doctor, I will always ask for a female chaperone, and so there will be a nurse with you who will maintain your modesty during examination. And it's always, these things are always much worse in your head than they are in real life. So you're not lying naked on a bed. You'll be covered with a paper towel, and your modesty will be maintained. And if there's not a chaperone with you, please ask for one. It's your right to have one, and you should ask for one. The second thing is that actually it doesn't hurt. It's uncomfortable in the sense that it feels a bit unusual, but it doesn't hurt. So your clinician will apply something called a proctoscope, which is a small plastic tube with lots and lots of gel, and it's very gentle, and it takes about a minute or so. So it really doesn't hurt. Having a colonoscopy is a different ballgame. So a colonoscopy is that bendy telescope test that I was telling you about. Typically for a colonoscopy, there are two major things that you really need to know. The first is that we would typically do that test by cleansing the bowel before we do it. So what that means is we got to get rid of all the feces in there so we can actually see the lining of the bowel. So your doctor will prescribe you quite strong medicine called bowel preparation, which is a purgative, and it sort of gives you. I tell my patients it's like rocket fuel. It gives you kind of terrible diarrhea, right? So if you're working, you got to take a day off work to have it, and that can be the kind of the most annoying thing. The second thing is that the camera, when we put it through the bottom and up through the bowel, it's got to go around a lot of corners in the colon, and that can push and pull a little bit. And it's a bit like having really intense trap wind. So quite often we will offer patients a bit of sedation. So that means someone will put a drip in your arm and they will give you medicine to make you feel sleepy. You're not having a full general anesthetic because we will quite often ask you to change position during the test, but you're definitely pretty chilled out. And many patients don't actually remember having the test. Mm-hmm. Some patients don't want to have any sedation, and that's cool. You can just relax and you can watch the TV screen and watch the colonoscopy happen as it goes on. And some patients also will have a bit of Entonox, or what we call laughing gas, so that will just relax them. So it's rare to have a general anesthetic for a colonoscopy. You shouldn't really need one, but do speak to your doctor about potential methods for, pain control during it, and I'll be very, very happy to give them to you.
Honestly, by the sounds of it, it sounds more pleasurable than a visit to the dentist, which is my top nightmare, to be fair. Maybe a colonoscopy is not as bad.
It's definitely much better than going to the dentist. I hate going to the dentist, but what I think it's usually much worse in people's imaginations than it is in real life. And I think what you have to remember from the other side of the fence, from the professional side of the fence, this is just work. And really all we're interested in is making sure that you're safe, that you've got the right diagnosis, and that you're going to be well looked after. And that's really all it is. And you should think about it in that way. I wouldn't describe it as pleasurable. Usually what I say to my patients is, look, there's better ways to spend a morning, but I promise you it's really not as bad as you think it is. And then, you've got a peace of mind and you can relax and you can get on with your life, and that you're as well as you can be.
Honestly, at a certain age, it sounds like these procedures become quite commonplace, if that's my understanding. Is that correct?
Yeah, for sure. So we're doing a lot of colonoscopy, probably too much colonoscopy is the truth of it. But one of the reasons we do it is to detect something called a polyp. And I mentioned that before. It's this benign growth. Bowel cancer doesn't just appear. It doesn't just suddenly appear. It typically goes through a series of transformations. And we know that a proportion of patients who have polyps will then go on to develop bowel cancer. So the idea of colonoscopy is to detect these polyps. And we probably find them in about 40% of the colonoscopies that we do. Now, the beauty is that we can remove them with a colonoscopy. And that's the major difference between the colonoscopy and the CT scan that I described to you earlier. And if you have them removed, that we know that reduces your risk of bowel cancer. So how and when we do that will depend slightly on the number of polyps that you have and where in the bowel those polyps are, and also what we find when we look under the microscope. And we will give you a sort of personalized description of how you should be followed up on that basis. The other thing that's really, really important, of course, is that if you're someone who has polyps, or we perhaps think you perhaps are at a high risk of bowel cancer, that you then have a chat with your doctor about what you can do to reduce that risk and how you can prevent that, from those polyps from coming back or from getting cancer again in the future.
It all comes down to the polyps. I'm not saying that now I'm freaking out and thinking about polyps, but I kind of am.
Yeah, no, don't. You're okay. But I think it is. It's basically an important part of the body's MOT that you need to have from time to time. And it's in the same way that we think about other prevention strategies. So for example, having a cervical smear if you're a woman, or a prostate exam if you're a man, is just part of that same process. And it should be as routine and as regular as that. And you shouldn't worry about it any more than any of those other tests that we all have to do.
What other things should we know about ourselves, potentially our genetic predisposition, or things that we should look out for, as well as how to make some lifestyle choices and changes to make sure that we give our gut the best chance to stay happy and healthy?
So the first thing to say is that we know that there's a very small percentage of people who have very strong genetic mutations that really significantly increase their risk of getting bowel cancer. And these probably account for 5% or less of all bowel cancers. And having said that, we think that probably we haven't tested as much as we could have done to identify those patients in the past. So one of these conditions is called Lynch syndrome. And the NHS now has a strategy to try and improve our detection of Lynch syndrome. And if you're in a family that has a really strong history of bowel cancer, so that means you've got a first-degree relative under the age of 40 who's got bowel cancer, or perhaps multiple relatives that have had bowel cancer that are a bit more distant, or there's a super strong family history of polyps, it might be worth mentioning this to your doctor. And in some patients, we will do genetic counselling. We will say, look, let's look at your genes and see whether or not you're in increased risk. About 20-25% of bowel cancers are what we call familial, which means that they don't have that really strong genetic risk, but there is something in that family dynamic that seems to increase your risk of bowel cancer. So there's something in the gene-environment interaction that drives it. But the majority of bowel cancers are what we call sporadic. And what that means is that they occur because the bowel is constantly sampling the environment that you live in. And to give you a sense of scale, in one day, your bowel will have to deal with more antigens, so these are kind of environmental agents that interact with your immune system, than the rest of your immune system will have to deal with over your entire lifespan. And so because you've got that constant environmental pressure on the gut, after around sort of 70 years of living, it's not uncommon to develop polyps or to develop, a cancer. And that's, you started by saying bowel cancer is the second commonest cause of cancer-related deaths globally, and that's kind of why. So then the final answer to your question is, well, okay, so what do we do about that? How do we reduce that? And the good news is there are lots of simple things that you can do, and you may well know some of these simple things. And those are either nutritional or dietary or lifestyle changes, basically. So the first and most important thing is to think about weight loss if you're a bit overweight, because we know that obesity is a major risk factor for it. Smoking is a major risk factor for it. So stopping smoking is really, really important. We know that we just don't eat enough fiber in the West, and that's a major risk factor for bowel cancer. Bowel cancer rates in the East and in sub-Saharan Africa are very much lower than we see in London and in the West, because we just have a very different diet. So reducing the amount of fiber, increasing dramatically the amount of fiber that you eat is very important. Try and get to about 30 grams a day if you can, but also reduce the bad stuff. So that means reducing fats, particularly trans fats, having too much animal protein, particularly red meats, and unfortunately reducing your alcohol consumption. And if you are going to drink moderately, and a little bit of red wine is the best thing to do. Finally, exercise. You got to exercise, everyone. It's really, really important. So that means 30 minutes, 3 times a week at least, where your heart rate is up. And we know that's really, really good for your gut. Now, there are lots of other kind of pieces of advice out there that we can get into, but those are the kind of headlines, I think.
Well, that's all been really helpful and amazing, James. I think we're ready to wrap up. Is there anything else that you want to leave us with on this topic, which has been really, really interesting to hear about?
So I think the thing that I just reiterate what I said at the beginning of this conversation, which is that don't be embarrassed, get checked. There's lots of people out there that want to help you. And, if you're worried, go and see your GP. I suppose the thing that we are very interested in our group is trying to understand why young people are getting more bowel cancer. And we don't really know the answer to that. But I alluded to the fact that I was going to explain why, and I feel like I probably should. So what we think is happening is that there is something called the microbiome, and the microbiome describes the sum of all the microbes that live within us, and particularly within the gut, and all of the things that they need to sustain and to grow. And we think that over the last 40 to 70 years, there has been a really big change in the diversity and the function of the microbiome. And that's because our diet has become globalized. It's because we travel more, and our social constructs have changed quite a lot, and the environmental toxins that we are exposed to have changed. And that relationship's really, really complicated, and it's difficult to simply unpick. We don't think there's one bad bacteria or one bad virus. It's probably a combination of these things interacting together. And over subsequent generations, this has had a cumulative effect. And it means that the immune system of the gut can't maintain itself. And we think that that's why mutations are spontaneously occurring in younger people and driving that cancer risk up. So a slightly long-winded answer, but that gives you a bit of insight as to what we're thinking about.
Well, I, for one, can say that even though I knew we were going to have this conversation, I prepared the questions, I did some little reading of my own, knowing that we were going to go into this. I found all this information really interesting. So thanks for that. At the same time, one thing that I want to emphasize is I know that these topics sometimes feel a little icky to some people, and, it stresses you out just thinking about them, so you don't want to learn about these things. But at the same time, that's what we're all about at Wype. We're all about taking care of your bum, taking care of the environment. And at the same time, we feel like this is an amazing opportunity to say things that happen in your gut and in your butt are telling you things about your body. So just be educated, be aware. These are things that are useful to know, especially when you're healthy and you're feeling fine, not when you're stressing out at 2 a.m. and Googling, why does my tummy hurt, right? So that's what we're here for today. And that's not all. We're really excited because we're going to go and see James in the clinic as the second part of this initiative. And James, where are we coming to visit you?
Okay, cool. So you're going to come down and see me at One Welbeck. So we have a big state-of-the-art day case unit there, and we have probably the largest collection of gastroenterologists and surgeons working together in London at the moment there, and I think you'll really like it. So we're really looking forward to welcoming you. I mean, if anyone listening to this has questions, I'm sure they can get them to you, and we'd be delighted to answer any questions that you may have, and we'll walk you through what happens when you come to see a doctor for any of the symptoms that we described.
Thank you so much, James. Thanks for sharing your time and your knowledge with us. I'm really looking forward to seeing you at the clinic as the second part of this initiative, and speak and see you soon.
Totally my pleasure, Georgia. Thanks for chatting.
Thanks. Cheers.
Have a great day.